Thank you very much for your interest in the recovery trial. This training talk is about two of the arms, aspirin and colchicine. This is the current design of the recovery trial. As you know, eligible patients, that is those admitted to hospital with suspected or proven SARS-CoV-2 disease, can be randomized into one of three different arms at the time of randomization. One of these arms is the early immunomodulation comparison, which is currently testing colchicine or usual care alone. Another one of the randomizations is testing aspirin as an antithromboembolic therapy with usual care alone. Participants may be randomized into one, two, or all three of these randomizations as they enter the trial. Colchicine, which is being compared in the early immunomodulatory therapy comparison, is a well-known drug which inhibits spindle formation in neutrophils and inflammasome activation. It is used routinely as an anti-inflammatory therapy in gout and pericarditis, and there is increasing evidence of its benefits in cardiovascular disease, for example, post-myocardial infarction or in chronic coronary artery disease. In recovery, the dose is slightly different to the usual regimen. Participants are to be given 1 milligram as soon as possible after randomization, and then a further 500 micrograms 12 hours later. They should then be prescribed 500 micrograms twice daily for a total of 10 days. If they are discharged during those 10 days, treatment should be stopped on discharge. Colchicine can rarely cause cytopenias, so full blood count monitoring is recommended. The frequency of this is at clinician discretion. For example, it could be at 3 and 7 days after randomization, but that can be more or less frequently depending on their baseline full blood count. Colchicine is contraindicated in the following situations. Colchicine is known to be teratogenic in animals, so must not be given to women of childbearing potential. Women under the age of 55 years old will be excluded from this arm by the randomization form. However, older women who may have childbearing potential or may be pregnant also need to be informed of this risk. Colchicine is also contraindicated in the presence of severe hepatic impairment or a significant cytopenia at baseline, for example, a neutrophil count less than 1, or a platelet count less than 50, or a reticulocyte count less than 20 if the reticulocyte count has been measured. It is not necessary to measure one simply to enter the trial. It is also contraindicated in the presence of strong cytochrome P450-3A4 or P-glycoprotein inhibitors. Examples of these include macrolide antibiotics, systemic azole antifungals, or cyclosporin. It is also contraindicated in people who are hypersensitive to lactose, as this is one of the main excipients. Colchicine can be used in the following conditions, but we would recommend the dose frequency is reduced, for example, 500 micrograms once daily rather than twice daily. These conditions include use of moderate cytochrome P450-3A4 inhibitors, or people with reduced kidney function, for example, an eGFR less than 30, or people with an estimated body weight less than 70 kilograms. If more than one of these factors is present, then investigators should consider excluding colchicine from the randomization. That is to say, to mark it as unsuitable on the randomization form. The main adverse effect of colchicine is diarrhea, which may limit tolerability and the treatment may need to be stopped early. As already mentioned, cytopenias can occur, but these are rare. Aspirin is the therapy which is currently being considered in the antithrombotic comparison. It has been chosen because it is a commonly used antiplatelet agent which also has anti-inflammatory properties. The dose in recovery is 150 milligrams once daily for the duration of admissions. People who are known to be hypersensitive to aspirin, who have had recent major bleeding or have a high bleeding risk, should not receive aspirin, and the drug should be marked as unsuitable for them. And the main adverse effect of aspirin is bleeding. We have chosen 150 milligrams as the dose because there is a potential risk of underdosing larger patients if we were to only use 75 milligrams once a day. And the bleeding risk between 75 and 150 milligrams is little different. You may wish to give gastroprotection with aspirin, and that is entirely at the discretion of the treating physician. And we are frequently asked what to do about other venous thromboembolic prophylaxis, such as low molecular weight heparin. The protocol states that patients should receive the standard prophylaxis that is normal in their hospital or determined by other trial participation, and this dose should not be changed. Participants should only be randomized to aspirin if the investigator is willing for them to have aspirin in addition to such a dose of heparin, and those doses should not be modified if they are allocated aspirin or control. Thank you very much for your interest in the recovery trial.